Hello. So I'm Dr. Tom Waddle, and I've been asked to do this webinar to update on adjuvant therapies for kidney cancer. Um, Hopefully it's useful for the audience. So I work at the Christie Hospital. Probably a lot of people on the call might know me. I treat kidney cancer and gastroesophageal cancer. And obviously the focus for today is around adjuvant therapy, and Sot was going to do a little bit around surgery, but I think he's held up basically having to operate instead. So there will be time for a Q&A at the end. Please feel free to add any questions into the question box. We can answer them potentially as we go along if there's anything that jumps out, but otherwise we'll go through a Q&A at the end. So I'll make a start. So just in terms of what I'm going to cover, a little bit of the background to adjuvant therapy in kidney cancer, what's gone before and sort of where we're up to, and then particularly focusing on recent trials and results, and in particular the Keynote 564 study, which many of you may already be familiar with. And then following on from that, what we are now able to offer patients in oncology and which patients are eligible, and then just finish with a few practical considerations. So in terms of background, we know that in patients that undergo surgery to remove locally confined RCCs, about 50% of patients will end up with subsequent disease recurrence. And that's the same really whether it's a radical or partial nephrectomy procedure. And the factors that are really linked to recurrence, I'm sure most of you on the call already know, but essentially it's many of the features that we use to form the Leibovitz score, so things like tumor size, the T stage, the N stage, the nuclear grade, and then some other adverse histological features that are not really included in Leibovitz, such as sarcomatoid histology or rhabdoid histology, and then also necrosis, which is part of Leibovitz. And so the Leibovitz score helps provide a way or one way to sort of quantify patients into groups and risk stratify them, and that gives us sort of low, intermediate, or high risk groups, which we use for the basis of follow-up. And as I say, that's not completely perfect, as in there are other adverse features that are not incorporated into Leibovitz, but that's sufficient for most of our day-to-day purposes. And then the other group that we'll talk about in relation to the trials is the M1 no evaluable disease, or M1 NED group. So that's a patient who's got metastatic disease, usually at presentation, but who has the metastatic deposit resected alongside the nephrectomy. And the commonest for that would be an adrenal metastasis, where we can often be removing an ipsilateral adrenal metastasis at the time of the nephrectomy. And those patients we know are at a particularly high risk of recurrence, because essentially we're confirming that the cancer has already developed the ability to spread, and we've got sort of a limited spread that's been removed. So we'll talk about these groups as we go. So in terms of adjuvant therapy, there's been a bit of a quest really for this sort of holy grail of what we would want from an adjuvant therapy. So an ideal adjuvant treatment would definitely improve cure rates after surgery. It should have a low risk of causing serious toxicities, so as not to be having too much of a downside. It would ideally be of short duration, and it would ideally be acceptable to patients. What we've had over the years that have gone by has really been evaluation of various TKIs over many years. So that includes sunitinib, sorafenib, pazopanib, and axitinib, as well as the mTOR inhibitor everolimus. And really, those studies looked at varying durations of treatment of between 1 to 2 years on treatments that do have quite a lot of side effects. And those treatments have all proven negative really in studies. The only exception, the only positive result, was that 1 year of sunitinib in the S-TRACT trial did improve disease-free survival, but didn't improve overall survival. And I think because 1 year of sunitinib is, pretty rough treatment with quite a few side effects, that hasn't really caught on and wasn't given a license or used in Europe. It was given an FDA license in America, but isn't really used. So essentially where we've been is with TKI treatments that don't improve cure rate, do have toxicities, and the duration of therapy has been around 1 to 2 years. So I think in general terms, the risks and benefits are not in favor of using any of those treatments. Then obviously immunotherapy came along, and there was quite a lot of excitement or interest in immunotherapy and what adjuvant immunotherapy might be able to do. So certainly since we've had the availability of checkpoint inhibitors, so drugs like nivolumab, pembrolizumab, those have really changed the face of immunotherapy treatment generally across the board in cancer treatment. And that's not just for kidney cancer, but for lots of different cancers, because the checkpoint inhibitors are much less toxic in general than previous drugs that we used to give, like interleukin 2 or interferon. So patients will feel generally more well on these modern immunotherapy treatments unless they get one of the autoimmune activated side effects. And we've also seen that an activated immune system may be more able to kill cancer cells, whereas the TKIs were maybe often sort of cytostatic, so stopping tumor growth, but not necessarily leading to regression. And even in the metastatic setting in kidney cancer, we were seeing, or we have been seeing, complete responses and remissions in up to about 10% of patients with some treatments. So we kind of had an idea that immunotherapy was killing cancer cells, destroying even some pretty large solid tumors in some cases. And that was something that wasn't previously being seen with TKI therapy. And really from all of that information, there's been a lot of interest in using immunotherapy in the adjuvant setting, where we think it might be easier to kill any residual cancer cells whilst they're still microscopic, rather than waiting until they form metastatic deposits and then trying to treat them at that point. So the main study really that we focus on, and that's because of the data that I'll come on to, is really the KEYNOTE-564 trial. And that was a randomized double-blind phase 3 trial looking at adjuvant pembrolizumab therapy. And that was patients with a histologically confirmed clear cell RCC. And I'll come on the next slide to talk about the exact staging that was eligible. But patients needed to have had their nephrectomy within 12 weeks prior to start of trial treatment. They couldn't have had any previous systemic treatment. They needed to be good performance status. They needed to have a tissue sample that could be tested for PD-L1. And the trial overall recruited 994 patients and randomized them between the two arms. So the arms of the trial were either intravenous pembrolizumab, 200 milligrams every 3 weeks for 1 year, or intravenous placebo every 3 weeks for 1 year. And the primary endpoint was disease-free survival, and secondary endpoint obviously looking at overall survival as well as safety. So this is just really to highlight who was eligible for KEYNOTE-564, which specific patients were allowed in. So if you had an intermediate to high risk clear cell RCC, then on the left-hand side is who was eligible. So if you had a PT2 primary tumor, then it needed to either be grade 4 or have sarcomatoid features. If it was a PT3 tumor, then it could be of any grade. If you were into the high risk category, so a PT4 tumor could be of any grade. And if you had any nodal involvement, then it didn't matter what the T stage was. And then there was this M1 NED group. So that was solid, isolated soft tissue met that could be resected either synchronous with the nephrectomy or within 1 year of nephrectomy. And I think most of the patients that were recruited were synchronous, because we don't do a lot of resecting metastatic disease within 1 year of a nephrectomy in general. And this is the patient characteristics. So this is who went into the study, median age around 60, which is probably a bit younger than obviously the real world population that we might be operating on. Predominantly male patients, which is what we would expect, and predominantly performance status 0, small number of performance status 1 patients. So again, maybe slightly fitter than what we see in the real world. The vast majority were without M1 NED disease, so about 6% of patients had metastatic deposits resected, and the vast majority were in that intermediate to high risk group, so the T2 grade 4s or T2 with sarcomatoids, or the T3 any grade patients formed the majority of the patients recruited. About 10% of patients had sarcomatoid features present. And this was the primary endpoint, so the disease-free survival. This is the updated results that were presented earlier this year at GU ASCO, so slightly different than what was in the publication, but essentially showing quite good separation of the two survival curves. So the pembrolizumab curve is the curve on top in green, and the placebo is the curve below that. And it shows that really about the hazard ratio of 0.72, meaning about a 28% reduction in the risk of recurrence. And looking at some of the sort of index figures, you can see there that at around about 2 years, for example, you've got 76% of patients disease-free in the pembrolizumab arm compared to around 67% with placebo. And that separation seems to persist. So it does seem that pembrolizumab is preventing or delaying recurrences, but I think we think preventing some people from recurring that would have otherwise recurred. And when we go into the forest plot, so this is just really looking at all the various subgroups, and really what you're just looking for with the hazard ratio down the middle is whether everything falls on the same side, which is still favouring pembrolizumab, or whether anything flips over to the opposite side of the line favouring placebo, and nothing does change. So essentially all subgroups seemed to favour pembrolizumab. Some of the subgroups cross unity because of smaller numbers, but I think one thing that does come out is that the M1 NED group, so patients that have had metastatic disease, did seem to benefit a bit more. The hazard ratio in that group is around 0.29, meaning about a 70% risk reduction for those patients. But importantly, the patients that don't have M1 NED disease still definitely benefit in hazard ratio 0.74, sorry. And then the other groups looking at really whether you're PD-L1 positive or negative didn't really seem to make a big difference. As we've seen in other trials, if you're PD-L1 positive, you maybe derive slightly more benefit, but even PD-L1 negative patients are deriving benefit. No difference according to male or female sex, no difference according to performance status 0 or 1. And then this was also the update at GU ASCO earlier this year regarding overall survival. So obviously it takes a little bit longer to see any difference in overall survival because these are patients that have had resection and don't have metastatic disease at diagnosis. So it's taken a while until you start to see any events or any patient deaths occurring. But essentially from when the curves start to separate at just less than 2 years, we do start to see a difference with more deaths happening in patients receiving placebo than in patients receiving the pembrolizumab. And the hazard ratio for overall survival, again, quite competitive, quite significant at 0.62, meaning about a 38% reduction in the risk of death for patients receiving pembrolizumab in this study. If we look at safety, then we definitely do see adverse events with pembrolizumab as we would expect. The placebo group is quite useful to have because, as you can see, we see a reasonable number of side effects from placebo, which just reflects normal symptoms and problems that patients might report. But roughly sort of a doubling of side effects in the pembrolizumab group. And when we look into what sort of side effects we see a little bit more fatigue. We definitely see more itch and thyroid problems. We see more diarrhea and skin rash. We see some hyperthyroidism, Not that much difference in terms of joint aches and pains. Those were quite common even in the placebo group. And then maybe a little bit more nausea or myalgia. And then if we focus specifically in immune-related adverse events, again, as expected, we see that those are pretty much all enriched in the pembrolizumab group compared to placebo. But the commonest of the immune events really are to do with thyroid dysfunction, which is also the easiest in a way to manage. Low rates of other problems like pneumonitis, adrenal insufficiency, diabetes, low rates of colitis or severe skin reactions. So although there is a risk of serious problems with adjuvant pembrolizumab, in general, the immune effects that we see are relatively manageable, and we probably quote to patients around about a 1 in 20 risk of something that would be more problematic, more significant, might need them to be admitted to hospital, might need steroid treatments, or might need us to stop treatment. So about 19 out of 20 patients are going to have either minimal side effects or side effects like thyroid issues that we can manage quite readily. So in summary from the Keynote 564 trial, it seemed that adjuvant intravenous pembrolizumab every 3 weeks for 1 year significantly improves disease-free survival with a hazard ratio of 0.72, and from the more recent update significantly improves overall survival post-nephrectomy with a hazard ratio of 0.62, and about a 32% rate of grade 3 adverse events in the IO arm, but many of those being thyroid dysfunction, and about a 22% rate of discontinuation due to AEs. So that all looks very positive and kind of straightforward, and like there should be no problem offering and giving everybody adjuvant immunotherapy. So what's the problem? Well, the problem is really that Keynote 564 was not the only trial looking at adjuvant immunotherapy, and so basically in parallel over the same years, we have had 3 other trials recruiting to very similar studies. So iMotion 010 was looking at adjuvant atezolizumab compared to placebo, and that has reported and is completely negative, and I'll show you the data for that in a second. Checkmate 914 had a placebo arm and then also had a single agent adjuvant nivolumab arm, as well as a combination adjuvant nivolumab with ipilimumab arm. And again, the update earlier this year is that both of those arms look to be negative with no improvement compared to placebo. And then the Rampart trial has compared surveillance against adjuvant durvalumab and an adjuvant durvalumab with tremelimumab combination arm, and we await the results of that, which are due within the next 6 to 9 months. But I think the expectation is that Rampart is likely going to read out as a negative trial as well. And so we may end up with 4 trials, with 1 that seems to suggest survival advantage and 3 that may suggest no advantage. And that creates a little bit of a problem for us trying to explain that to patients or to figure out why that might have been the case. So these are the negative curves that we've had. So on the top left is iMotion 010. You can see the curves there are completely overlapping between the placebo patients and the atezolizumab treated patients. In the 914 combination arm, again, very similar, pretty much overlapping curves, no suggestion of any benefit. With the single agent nivolumab, there is a very slight separation, but really nothing that reaches any statistical significance, and the hazard ratio still comes out very close to 1 with no proven benefit for single agent nivolumab. So why would those results be different? Well, obviously they are different drugs, but they're very similar drugs. So pembrolizumab is an anti-PD-1 antibody. Atezolizumab is an anti-PD-L1 antibody, so has a slightly different target. And maybe atezolizumab has performed less well in other trials as well. So it's possible that that's the reason for that being negative. But I think the big surprise really is nivolumab, which is also an anti-PD-1 antibody, really thought of as a very, very similar drug to pembrolizumab. And in the metastatic setting, really those 2 drugs do very similar things. So it's a bit tricky to explain why nivolumab would be negative if pembrolizumab is positive. Maybe because of different patient populations in the trial. The other trials didn't include the highest risk group, that M1 NED group, but that was only about 6% of the patients in Keynote 564. So whether that would be enough to alter the result. Is it that the Keynote 564 result is wrong? Is it a false positive finding? Well, I guess that's always possible, but this was a big randomized phase 3 trial with 994 patients, and it had very good statistical power, and the result from that trial looks quite convincing. So essentially, at the moment, we're not quite sure how to explain the difference in the results, and we await Rampart, which may give us more information in one direction or another. Importantly, Rampart is also the only one of those studies that included some non-clear cell patients. So Rampart will also give us the first bit of data for immune treatments adjuvantly for non-clear cell. The rest of the trials have all been focused only in the clear cell population. So basically, despite the sort of controversy or the conflicting results, Keynote 564 and MSD went forward for an approval and have been licensed in America and Europe and have gone through the NICE approval process. And we do now have pembrolizumab available, as you'll be aware from the MDTs, for adjuvant treatment of resected renal cell carcinoma. Just as a reminder, so the NICE approval is restricted to the patients that were eligible for Keynote 564. So patients have to fall within these criteria for us to be able to access the drug. So if it's PT2, that means it has to be grade 4 or sarcomatoid. The T1B high grade ones, unfortunately, are not eligible, even though they fall into Leibovitch intermediate. They were not included in the trial, so we don't know if the treatment is beneficial for them. PT3 certainly is fine, regardless of grade, and certainly the higher risk groups like PT4 or node positive patients. And then the M1 NED group obviously is appropriate, but that represents a very small percentage of the patients that we see in the network and that undergo resection for metastatic disease synchronous. Patients should be performance status 0 to 1, and importantly, we need to start the adjuvant pembrolizumab within 12 weeks of the date of surgery, which I'll come on to, but that obviously causes us some problems within the network and within our normal patient pathways. We need to see the patient and then arrange a restaging CT scan to confirm no evidence of recurrence prior to the start of therapy. And with the NICE approval, we have the option for either 3-weekly or 6-weekly intravenous pembrolizumab. And in general, because of that option, most centres have decided to use 6-weekly pembrolizumab. It's essentially just double dose and half as often. So it makes things a bit easier from a service perspective, makes things a bit easier from a patient perspective. So we give an intravenous dose of pembrolizumab every 6 weeks, and that means 9 doses in total over a 12-month period. So the NICE approval did include approval across lots of different RCC histologies, so it isn't just approved for clear cell, but the problem really is that we don't have any data to support the use of pembrolizumab for anything other than clear cell. So until we have any data that suggests otherwise, at the Christie, we're not offering pembrolizumab for any histology other than clear cell, and that's pretty much in line with UK and international practice. So although the license and the approval is a bit broader, I think it's important that we're not using a drug for patients where we don't have any data to support its use, and particularly given the controversy with the conflicting data even in the clear cell space. For renal function in Keynote 564, patients had to have an EGFR greater than or equal to 30, and that seems reasonable as a cutoff, so that's pretty much what we're trying to stick to. We would be a bit worried about increased risk of toxicity or nephritis in patients with a lower EGFR than 30. Patients shouldn't have any other, basically any other competing significant risks for survival. So that would obviously include other metastatic malignancies, also other health conditions that might be expected to have a short prognosis. Obviously, these patients have already all gone through a nephrectomy. So in general, they should be fit enough to be considered for adjuvant pembrolizumab from that perspective. So just lastly, a few practical things to think about really within the network. So I think at the MDT, what we need is ideally a sort of timely discussion, ideally by week 4 post-op. I realise sometimes that the histopathology full results and things are taking a bit longer to come through, but I think we would want to prioritise these radical patients that might have adjuvant therapy options for MDT discussion by around week 4. We would need to confirm that they have clear cell histology, and we would need to know essentially the other factors that we would need to determine suitability for adjuvant pembrolizumab. So TNM stage, tumour grade, presence or absence of necrosis or sarcomatoid features, and calculate Leibovitz score. And the patients need to fall within that Keynote 564 or NICE criteria for us to be able to offer them treatment. And then also at MDT, we need the relevant information regarding the patient, how they're doing post-operatively. So performance status, their post-op renal function, and any relevant comorbidities. What I didn't mention up until now would be anything in terms of comorbidity that might be a contraindication to immunotherapy. So there would be patients fit enough, obviously, going through nephrectomies who might have history of Crohn's disease, ulcerative colitis, or significant other autoimmune conditions, and those patients would be excluded from pembrolizumab, as well as patients with other ongoing malignancies present or significant other comorbidities that might be competing risk for survival. Then at the surgical clinic review, I think it's key really that post-op clinic would take place ideally prior to week 6 or around week 6 at the latest, because we need time for you to be able to make a referral and for us to then arrange to see a patient in an oncology clinic by around week 8. And that's because we need time to see the patient, go through the counselling process, and if they're interested, then get a restaging CT scan to confirm no evidence of residual or recurrent disease prior to the start of treatment by week 12. So we might want to look at the pathways, really how we're booking that, because it seems at MDT that not all patients do have a post-op review already lined up back in the surgical clinic by week 6, and it would be ideal if that could be done as a matter of course, so that all patients at the time of nephrectomy have their post-op review booked within that sort of time frame. And then just to say that if the patient is suitable for adjuvant and you're making a referral, please make sure that that's marked urgent and typed urgently and sent across urgently, because we did lose quite a lot of patients in the early stages, particularly where the letter was dictated from a clinic but didn't reach us until around 4 to 6 weeks later, at which point they were outside of the window for us to be able to see them or give any treatment. And then in terms of what to say at surgical clinic review, obviously it's important to discuss the possibility of adjuvant treatment with relevant patients, and then refer only if the patient is interested in possible further treatment. I think from our point of view, it's probably important that it's not a you must have this treatment. We don't see the patient and say you definitely need to have this. This will definitely benefit you. It's more because we don't know which patients do need the treatment or who is definitely benefiting. It's more of there is a possible treatment available that you might be interested in, and then we go through all the data with them. So probably in terms of making the referral, it's letting them know that there is a treatment that they might be interested in. It would be useful to inform them that it would be intravenous treatment. We still get a lot of patients turning up in our clinics who think that they're being referred for oral immunotherapy, and there is no such thing as oral immunotherapy. So it's an intravenous treatment every 6 weeks for 9 doses over a 12-month period, and that's probably as much as would need to be sort of put to the patient in a surgical clinic to check if they're interested in the referral. And then basically when we see them at the oncology clinic review, we will then do a lot more counselling around the risks and benefits. So Obviously, it depends whether they're in the intermediate or the high risk category, what their Leibovitz score is, what their absolute risk of recurrence is as to how much benefit they might get from the treatment. Obviously, the absolute benefit is higher if they have a higher risk, which is also confirmed by the M1 NED group, who have the highest risk and therefore the highest chance of benefit. So we would definitely speak to them about the side effects and toxicity. And obviously, if you're an intermediate risk patient, you still have the same risk of getting significant toxicity, but slightly less risk of benefit, and importantly, slightly lower risk of relapse if you did nothing. So it's quite an individualized discussion with the patient, and we're finding that patients are making different decisions presented with the same information. The overall survival advantage from the update earlier this year definitely helps a bit with that, because we're able to tell them that we do think it would cure some patients. If the patient is interested in going ahead, we will then request and arrange an urgent restaging CT scan at the Christie Hospital and review them with the result. And we would then, with that, knowing that the CT is clear, we can then request funding, consent, and get started. And as I say, the target is to commence within 12 weeks post-op if the patient is interested. So hence the need for a bit of pressure on the pathway. And I think that's all I had in terms of what I wanted to say about adjuvant therapy, but I'm very happy to open things up to Q&A or take any questions, either typed into the chat, or I don't know if people are able to potentially unmute or raise questions in other ways. I'll be guided by the Academy team. Thank you very much.
Thanks, Tom. I think we will just open up, give a few minutes for any questions. Please submit your questions in the chat box you'll see on your screen. Unfortunately, there is no option to unmute and request them that way.
Thanks. So I'll maybe just answer the questions as they come in. So are there any specific contraindications to Pembro? Yes. So essentially, its significant autoimmune problems would all be contraindications to Pembro. So I guess what is not a contraindication amongst autoimmune things would be things like well-controlled rheumatoid arthritis or well-controlled diabetes, for example. Similarly with skin, things like psoriasis or eczema, if they're controlled, that would be fine. But if they were needing to be on any immune suppressive therapy to control that, so that would be maybe rheumatoid patients on significant doses of DMARDs or skin toxicities that are needing systemic treatments, then that would be a problem. And then the main things really are colitis is a problem, even if they have quite quiescent, well-controlled UC. It will almost certainly flare as soon as you give a dose of pembrolizumab. Other things like myasthenia, Guillain-Barré, anything like that, really would be an absolute contraindication that you would be much more likely to harm the patient. And even things like asthma, we've had a few patients where they've had asthma, but they are on some of the systemic asthma immune suppressive treatments, sort of autoantibodies or newer immune suppression. Then really, it's kind of wouldn't really make sense to have someone on an immune suppressive treatment at the same time as trying to give them an immune boosting treatment. So unless it was thought that they could stop those treatments or that it would be safe to take the risk, those sorts of things would be contraindications. If you're unsure about that, then feel free to refer a patient and we can sort of assess that. But I think if they've got a definite history of Crohn's that's needed any surgical intervention or something in the past, then really we're not ever going to offer that patient adjuvant pembrolizumab, regardless of risk, because they would be better served taking their chances. So hopefully that answers that. And then Ewan's question. So what we plan to do in terms of monitoring is to see them obviously through the year of treatment. We scan them. They have a scan up front. They then have a 6-month scan with us during the treatment and a 12-month scan with us at the end of treatment. and then we're seeing them around 3 months after that if they've had any immune complications to make sure essentially that they don't have any ongoing immune problems. And if they're recovered from treatment without any immune complications, then at that point we would plan to refer them back to local surgeon for the rest of their follow-up. So essentially we'd be seeing them out to about 15 months, or I guess they'll be 18 months post-op by that point because they've started treatment at about 3 months post. If they had the patients that have had immune problems, so if there are people where we've caused significant colitis or other problems and they're still unwell from those problems or needing steroids and things, then we wouldn't pass them back until we were at a point where they'd weaned off any treatment and we were happy that there weren't any ongoing immune problems. So essentially we're not expecting for you guys to be taking over management of immune problems that we've caused, but if they're doing well, then we are planning to hand them back for the rest of their follow-up. And then next question, for patient with an IMDC intermediate or poor group with resectable disease, i.e. achievable M1 NED, is it advisable to use Pembro? So there's a lot of debate about, there's not so much debate about is the synchronous resection. So I think a patient with an adrenal met that can be taken at the time of your nephrectomy, that's kind of what we always did anyway. And I think if that patient is then rendered disease-free, it's reasonable to offer them adjuvant Pembro. What we're struggling with is this concept of a metachronous metastatic deposit that then gets resected within 1 year of nephrectomy, because essentially that patient has been clear preoperatively on their scans, they've had a nephrectomy, and within less than 12 months they've developed metastatic disease. We wouldn't normally, in that setting, advocate going in and resecting the metastatic deposit because we'd be worried that that patient doesn't have very favourable disease biology and they may well be going to pop up other sites of metastatic disease. So I think around the country and around the world at the moment, there is a bit of debate about that, but I think people are not really thinking that what that patient needs is another operation so that they can get on to adjuvant Pembro, rather than thinking they're at risk of widespread metastatic disease and they should maybe be referred to consider systemic treatment up front, in which case we would be able to use combination treatment, so IO plus TKI or a doublet IO regimen, and then resect them or sabre them or something later down the line. So I think the worry would be basically for that sort of patient, putting them through a resection followed by adjuvant Pembro might be sort of under treatment, given that they're developing new metastatic disease that wasn't present at the time of the original resection. And just to say again, that M1 NED group, it had to be within 1 year of nephrectomy. So obviously the patients where we do think about surgery quite often are people who are maybe 5-10 years down the line from nephrectomy and they develop one site of metastatic disease. We're very comfortable resecting that sort of patient because the disease biology looks favourable, but they won't become eligible after that sort of operation for Pembro because the timeline is way too far down the line. So yeah, it's a little bit of a grey area, those metachronous mets to resect. But I think, so if you did resect, we could offer adjuvant Pembro within 1 year, but I think that wouldn't probably be our preferred pathway for that sort of patient. Hopefully that makes sense. Any other questions or thoughts? I'm happy for those slides to be sent round, shared broadly. Hopefully it kind of helps. I've tried to emphasize the things that I think are key for the surgical team to know in clinic, and timelines and that sort of thing for MDT and surgical clinic discussion, because I think these are the pitfalls that we've had since we've started offering the treatment, that we've had maybe some potentially eligible patients that we've not been able to start in time. Otherwise, we will probably call it a day there and everyone can get on with the rest of the day. Thanks again for your attendance. Hope it was helpful. Cheerio.